Okay, we can start, sir.
Sure.
Bismillahirrahmanirrahim. It's a great honor for me to start the third webinar of the Egyptian-Indian online orthopedic course. First of all, I would like to thank my dear friend, Dr. Sernifas from India for giving a great help and great support to complete this preparation of such a great eminent course between eminent stars from two eminent great countries, Egypt and India, with two great history all over the world. It's an honor for us tonight to have two guest speakers from India, Professor Rajesh Malhotra from India, one of the eminent stars of arthroplasty in India, and from Egypt, Professor Mahmoud Mabrouk from Azhar University, also one of the eminent stars of arthroplasty surgery in Egypt. We will start with our dear Professor Rajesh, and Dr. Sernifas will introduce Dr. Sernifas, please, sir.
Thank you very much, Professor Elashab. I would like to thank the Egyptian Orthopedic Association as well. It is my pleasure to introduce our esteemed speaker for today's talk. He will need no introduction in the Indian orthopedic among Indian orthopedic surgeons. Professor Rajesh Malhotra is a renowned and accomplished expert in the field of arthroplasty in India and abroad. He's the head of the Department of All India Institute of Medical Sciences, New Delhi, which is an apex academic institute in India. And he trained many undergraduates and postgraduates from AIIMS, and he has made significant contributions in the field through extensive research, publications, and presentations. He has a brief account of his achievements. So he did his graduation and post-graduation from AIIMS and has been consultant since 1992 and currently heads the department and associated Apex Trauma Center at the AIIMS. He has been past president of the Indian Orthopedic Association and has done multiple fellowships in arthroplasty. He is very active academically and is a reviewer of over a dozen national and international journals. He has over 900 publications and an equal number of presentations, and among the top 1% researchers in the world. And he has delivered several orations and written many books and chapters. He has been in the national task forces on osteoporosis, road traffic accidents, stem cells, and bioengineering as part of the Department of Biotechnology. And he has received the nation's highest honor for any doctor in the form of BC Roy National Award in 2014. He has also received multiple national awards for his services in teaching. Thank you very much, Professor Rajesh Malhotra, for accepting the invite to give us this talk. Over to you, Professor Rajesh Malhotra.
Thank you very much. Thank you very much, Dr. Srinivas, for your kind introduction. And I'm really honored to be spending time with the Egyptian orthopedic surgeons. And what I'm going to talk about in next 35-40 minutes is my lifetime experience of dealing with hip and knee arthroplasty. And as the brief is for today, how it is different in India and South Asia. So I'm going to talk about the difference between the Indian and Western population in terms of etiology and anatomical differences, the late presentation, poor bone quality, lack of family support, and poor affordability, which all play important part in the treatment. So I'll start with an example. This is a man who had an hemiarthroplasty gone wrong. It was infected. He has had 16, you heard it right, 16 surgeries to control infection, debridements and all. Now he's about 16 centimeters short. He's got a deformity. He's got that spacer which is coming out, and he's got this skin which is badly scarred. So the challenges here are skin incisions, multiple scars, bone loss, shortening, deformity, and then which implant to use. So extensive debridement was done once we found that after these 16 surgeries, 15 of which were debridements, infection could be controlled. Now he had a proximal femoral deficiency. So we did the distal femoral osteotomy at the level of the deformity, and then put this hydroxyapatite coated reef stem by DPU Johnson and Johnson with the distal locking option. You see, no stem will give inherent stable fixation here. So you need something like an interlocking stem here. And because of the poor bone quality, the hydroxyapatite coating, he is still about 2 inches short. And it was quite an effort to gain this much of length. And how I do it is to actually somehow get a reduction and then use successively bigger heads because I have done all the soft tissue release, and then use the next size stem, leaving it a bit more proud, and do over and over again till the time I thought that I cannot lengthen it anymore, and still was about 2 centimeters short. But this is what I can do it after he has been with this for 20 years with multiple surgeries. So the challenges in total hip arthroplasty in India and Asia: age of presentation, diagnosis, neglected childhood pathology, which can have bony and soft tissue issues, and trauma, and the prior osteotomy, the problems of infection, osteoporosis, anatomy, and cost. So you see, two-thirds of my patients are under 55 years of age compared to 13% of the patients in Australia. So our patients are young. So I have to be conservative. And most common indication for total hip in India is avascular necrosis, which has actually become even more common now after the COVID pandemic because of the steroids and the COVID per se. And this is why I believe in conservative hip arthroplasty. This man has come to me at the age of 25 years. He had a septic arthritis of the hip at the age of 7 years. Then at the age of 12 years, somebody did a hemi replacement. The x-rays are not available. Then at the age of 15 years, somebody changed it to a cemented hip. And now he came to me with a broken stem, and not came to me with broken stem. The stem broke, and then somebody tried to revise, but he could not take out this part of the stem. And this is how he presented to me at the age of 25 years. Look at the bony deficiency in the acetabulum and in the femur. And this was the CT scan and the 3D reconstruction. We always do an angiography whenever there is a cement like this. We don't want it to be stuck to the vessel. And when we try to pull it out from here, there's a torrential bleeding, and then it cannot be controlled. I'll tell you more about it. So we did an angiography. We saw the vessels were about 0.8 millimeter away, but then they were not stuck to the cement. And this is what we did. We took out everything. There was a big defect on the acetabulum and the femur. We put this trabecular metal augment and a shell, and then this is a trabecular metal revision shell. And after that, we put a Wagner stem, tried to put the greater trochanter in place. So this is the follow-up X-ray. But look at this. This is man is just 25 years old. And now he's got his whole life in front of him. So this is why if the first surgery is very conservative, you have to be, then he would not have burnt all the bridges. Another classical example. This lady came to me with bilateral septic arthritis of the hip. She didn't come to me. She had a septic arthritis of the hip, bilateral. So this was fused, and somebody decided to do this hip replacement. So he did this. Now, obviously, you can see with this kind of pelvic obliquity, this is not going to stay. And this is what happened. She came to me like this. So I told her, first, I have to fix this, because unless I correct this and the pelvic obliquity becomes straight, this will keep on dislocating. She was not willing. Finally, she agreed because there was no pain here. She didn't want a surgery here. And I went in, and the anatomy was so badly distorted because of septic arthritis, and the bone stock was so poor that I could not do a hip replacement. So I had to do abandon, and I grafted whatever reaming I had tried to do for acetabulum. But then it was a girdle stone. The pelvis could become straight. So I did this hip replacement. And then the COVID came, and she came to me after 2 years to get this done. So I did the second side, and this is her current situation. She's improving, and hopefully she'll improve even further. That's the EOS imaging picture of that patient, and she is doing quite all right. So the concept is, we had to operate on an asymptomatic side, because without that, this would have failed. This scenario we see very often in septic arthritis and in the poliomyelitis. So because of these reasons, which I told you, where the patients have to undergo surgery at a very young age, I'm very, very conservative. You see all these, I have done all of these because my patients are very young. This is the son of the first Arjuna awardee of the India. His father was a sports person. He's a sport person. He came with this from USA and said he wanted a resurfacing done, which I did. And then I want to tell you that I never told him to do this. This is what he is doing after one side replacement. And that's because this is a big problem in the hip arthroplasty for young patients, because they want to do everything. And that's why one has to be very, very conservative, because they have to be hard on hard bearing and they have to last long. And I told him he's in Japan right now. And he sent me this video that this is what he is doing. And I told him that when you come, the first thing I want is to do the serum metal ions on you. Because I don't want that your serum metal ions are going high. But this is a classical example. Because he was abroad, I told him to send a video, and this is what he sent. This is what they are doing. So this is what the young patients expect from us. So we have done resurfacing for inflammatory arthritis, which is the commonest cause of arthritis in young patients, has been till the COVID took over, and we have published extensively on its use in the inflammatory arthritis. So this is the other hip, which is the Birmingham hip mid-head resection. Again, for young patient, we have published that the mid-head resection preserves the bone stock around the proximal femur. This is a silent stem. This was from DPU. Again, an attempt at conservative hip arthroplasty, because in our part of the world, the patients are very young and you cannot start burning the bridges at a very young age. So this is another example. This was the Proxima by DPU. And again, this is about 6 years post-op. And I continue to do quite a few of these till the time I had to revise one of these. And I realized you cannot revise it without destroying a lot of bone. So they are bone preserving, but not bone conserving. So when you operate on it, you save bone, but you take out, then you are not conserving any bone. And that's why I stopped doing this. In the meantime, it was withdrawn. We published our results of short metaphyseal stems in young patients, and we also presented. I presented it in the British Hip Society meeting in Manchester in 2009. We have been doing short stem in young patients, and we have recommended that there is a high risk of split, and you should do a prophylactic wiring in patients who have avascular necrosis associated with the renal disease, steroid abuse, or alcohol abuse. This is a young guy. He had at the he has chondrolysis at the age of 14 years. He's in severe pain, and his father had to carry him to the school in his lap, and he just couldn't do any activity of daily living. This was the youngest patient I operated, and this is how young we can get. And even if I get another couple of years younger, I will not hesitate to operate and do it, because the patient is totally disabled and has a very poor quality of life. Now, when you have these young patients who get this hip disease because of avascular necrosis or whatever reason in India, the cosmesis is another problem. So I have been doing the bikini incision direct anterior approach, and they get a scar with a subcuticular stitch, which is not even noticeable. So this is a bikini incision, direct anterior approach. This is the hip as it looks, and this is after the closure and after the skin incision, and the scar is hardly noticeable. And we think that the women in all part of world need, they have vanity, and they are entitled to a cosmetic surgery in addition to giving very good results as well. Now, talking about the small stem, it's often said that small stems provide solutions for big problems and big challenges. For instance, this patient who has got a hip arthritis but extensive implant throughout his femur. And all I did was actually to take out a few screws from the top and did a short stem. So the surgery gets over in half an hour rather than a half a day surgery where you remove all these implants and then there's a lot of blood loss and risk of infection. What will you do in this? This patient has a, retrograde nail and he has a plate and he's got a condylar blade plate on top and he's got an arthritic hip. It'll take whole day to take out all the implants. And this is what I do. I just took out the implant on the top, took out one screw from the plate and put in a short stem. So for young patients and also for complex situations, the short stem comes to your rescue. The other thing which comes to the rescue is a modular stem, like an S-ROM stem from DPU. So this is a 33-year-old male who had painful right hip arthritis for last 1 year. He was on daily analgesics for last 1 year. He had a septic arthritis at the age of 10 years or 11 years. That was nearly 20 years back. He has flexion deformity of the hip. It was drained. There was an incision there. He has a stiff hip and a flexion deformity. Now, if I go from the posterior approach, I'll violate all the tissues on the backside and cause scarring, which will be very difficult for the next surgeon who has to go in to revise. So what I did was I did a direct anterior approach. You have the advantage of the fluoroscopy. You can see the size, the version, and the depth of the vestibular cup which you are doing, and you put the definitive implant. This is him now. He suffered for more than 20 years, and now he's so excited that he is able to do everything, and he's actually very active and doing all activities of daily living very happily. The point here is that you have to keep the patient's age and the activity level in mind when you give them treatment, and also have to keep the next revision in mind, conserve as much bone as possible. And because of this direct anterior approach, we could also do the daycare hip replacement, because and this was long time back, mainly prompted by the COVID pandemic. And again, because it's very painless and you don't cut any muscles, it is remarkable how fast these patients recover. So I was talking about the modular stem. So this is an 18-year-old female who had a childhood infection. She's got a hip almost like a high riding crow 4 kind of dysplastic hip, although the etiology here is infection. And you have to have special tools, because in these cases, many times you will have very sclerotic bone, and then you need the burr. If you don't want to perforate the femur, you burr this bone here, and then you do I had to do a subtrochanteric shortening osteotomy here, and this is the 6 years follow-up. She's doing quite well, surprisingly not very short. And we have published our results of total hip arthroplasty for septic sequelae of childhood, as well as the dysplastic hips. And most of these cases we use highly cross-linked polyethylene liner, because the instability may be a problem, and these are very small sizes. And in India, we get ceramic liner only from 46 or 48 millimeter onwards, so there is no other option. Another problem which we face in this part of the world is ankylosing spondylitis, which leads to the fused hips, which makes it impossible for the patient to sit or walk or even stand, and it makes very difficult to position them on the table. So this was the patient who was impossible to position in the lateral position for posterior approach. This was before I was doing the direct anterior approach routinely. So I did the anterior incision of the 2 incision MIS. Those of you who know, in 2004, 2005, this was launched by Zimmer. This was a 2 incision MIS where a small incision was given here, and through that the neck was divided and the head was taken out, and the acetabulum was prepared, and then rest of the thing was done like an intramedullary nailing. Here I used an image intensifier to cut the head, and then I went the usual way by the posterior approach. This patient couldn't sit because of the gluteus maximus contracture, so I did a Z-plasty for the for the gluteus maximus, and see, he could sit after the surgery. These are the X-rays. He is actually quite happy. He can sit now. And so these are the cases where you have to keep the soft tissue considerations in mind. And we published this in Journal of Arthroplasty, a technique of Z-plasty of the gluteus maximus for the gluteus maximus contracture. Now, other thing we must realize, we have a lot of arthritis and the rheumatoid arthritis and the ankylosing spondylitis. I just showed you ankylosing spondylitis, but sometimes these patients have a pseudoarthrosis in the spine. So no patient of rheumatoid arthritis or ankylosing spondylitis should be taken up for surgery without the whole spine X-ray, including the cervical spine, for the cervical atlantoaxial instability or the Anderson lesion. Now, this particular patient was being operated by one of my colleagues, and he was a junior actually, and he put the trial implants inside, and to correct the flexion deformity, he tried to extend the hip, and he broke the spine into two because it was already weak there. And the young girl that she became paraplegic and lived as with paraplegia for the rest of her life. I had another patient who my physiotherapist said, you have done knee replacement on a lady and she cannot walk. She was walking till last week and now she cannot walk. So I rushed to the physiotherapy to see her, and I found that the muscle power in the lower limbs had gone down considerably. So I just did one thing. I asked her to hold my hands, and she had a weakness of the grip also. And we got the cervical spine X-ray done. So she had atlantoaxial subluxation, and then that was fixed and she recovered completely. So do not take rheumatoid arthritis and ankylosing spondylitis, which are common in this part of the world, lightly. This is another patient, mucopolysaccharidosis. She came, she said she wanted to get operated by me. I said, okay, let's look at your craniovertebral junction, and we found basilar absence of dents and the atlantoaxial subluxation. So she's waiting for the fixation by the neurosurgeon before I will touch her. So remember, whenever you look at a disease which can affect the spine, just do look at the craniovertebral junction, the cervical spine also. The other issue with the soft tissue, like I showed you for the extension, the gluteus maximus contracture, is very common, is the post-polio residual paralysis. You will still get some patients who come to you with the post-polio residual paralysis with a hip like this, and then they are contracted soft tissue like this. If you see, it's not very different from the septic arthritis windswept deformity which I showed you. So again, without taking care of this side, you should not touch this, because that's exactly what will happen if you do not take care of the abduction contracture on this side. So many times we have taken the patient to theater, did the sutures and younds on this side, checked under image intensifier that the pelvis is square or nearly square, and then we do the hip replacement on that side. So this side will need the modular stem. I told you, for all abnormal proximal anatomy, S-ROM type of modular stem is ideal. You may need an iliolumbar fascia release if there is a supra-pelvic deformity. You need sutures release for hip contracture and Young's release for the hip and spine contracture. So this was released, but it will take a little bit of time to come back to squaring. So we give the shoe raise, under correction of shoe raise for residual limb length discrepancy, so that gradually it becomes corrected. And we publish in the bone joint journal our algorithm, which essentially talks about whether there is a pelvic obliquity or not, whether there is a suprapelvic contracture or not. And then if there is no suprapelvic contracture, then infrapelvic pathologies are addressed and soft tissue releases are done before the hip is replaced. This is published in BGO, Bone Joint Journal, open access. You can see it anytime. So what about the deformed proximal femur or post-osteotomy? You will find many times the patients who have undergone a McMurray's osteotomy and some kind of proximal femoral osteotomy. And again, the S-ROM kind of stem is the ideal stem for this. And this is a 7-year follow-up for the same patient. Many times we turn this sleeve 180 degrees. If there is not enough bony contact here, the sleeve can get bony contact here. So the sleeve will look like this. And then you can put the same stem like this. This was a Wainwright plate, or a spline as we call it. And I did this and I made the mistake of not checking the X-ray in the theater. So I was going for a conference. My team rang me up frantically and said, this stem is out. So then I took her up for surgery, came back, took her up for surgery, made sure that because many times the sclerotic bone will actually misguide the stem out of the femur. I use the burr, put it in, and above all, check it under the image in the theater. And she is now almost 9 years solidly united, doing quite well. Another example of proximal femoral deformity after a fracture, and you can see that these can be handled very well with the modular stems. So I have written books on primary hip, primary knee, revision hip, revision knee, but many of these tips you will find in my book. So this is other condition, neglected trauma. Not at all common in this part of the world. It may not be common in the Western world. So they come to you with severe bone loss, and many times you have to use special implants. This is octopus cage. Unfortunately, is not available now. It has been withdrawn. I'll tell you what we do now in its place. This is what we do. We use the cup cage construct, but then the original cup cage by Zimmer is not available in India. The trabecular metal revision shell is available. So I found that I could use a Burr Schneider cage on top of a trabecular metal shell. And if the Burr Schneider cage is 16 millimeters smaller, so you use a 60 millimeter shell and use a 44 millimeter Burr Schneider cage, it will really fit very well and sit inside. And then you can cement a liner or a duo mobility at that. And we have published our results with this. So we have also published our recommendations for total hip arthroplasty in acetabular fractures because it's so common. Infection is another thing which is very common anywhere in the world, but we particularly have infections like tuberculosis. So when you have an acetabulum like this, which is sclerotic, bald, it will not give any bonding with cement. So you need a cementless shell, but then you need a cementless shell with very high coefficient of friction. So what you use is a porous metal cup, like I did here, with some bone grafting in the floor. This is a Regenix cup, and it does quite well. Another example where it is almost like a dysplastic hip and subluxated, had ATT 9 years back, is a post-tubercular sequelae. And in this kind of situation, you have to use an SRAM type of modular stem for this. So we have published our recommendations are totally arthroplasty in tubercular arthritis of the hip, the surgical challenges and choice of implant, but we routinely start them on ATT, even if it is hail tuberculosis. 2 weeks before surgery, we start them on ATT, and we continue it for 3 months. Another example of a neglected case, bipolar done 20 years back, no check X-ray taken after the previous surgery. She came with severe pain and shortening, and she has such a bad bone quality that I thought I'll do a grafting here, allografting here, and a porous metal cup, and I'll use a Wagner stem here. But the bone quality was so poor. You can see the Wagner stem here. The bone broke from the bottom. So I had to wire this distal part, take out that Wagner stem, and then put a longer Wagner stem. This is the Wagner stem which had to be taken out, and then we had to do the wiring. And this is how I reconstructed the acetabulum. I've got my special technique where I put alternate layers of morselized allograft and injectable bone cement, and that solidifies within 10 minutes and gives solid rock support. And these were all prophylactic wire, and this was a Wagner stem which was done. This is another example. This lady has a son who's a doctor and another son who's a lawyer. So she had this nailing done, and she got this fractured neck of femur without even realizing that she has a fracture. Now she has, the nail is tending to come out from below, and because the nail has been in for so long, I didn't even know whether I'll be able to take it out. So I was lucky I could take out the nail, and this is what I did. I put a prophylactic plate on that femur, because that femur was osteoporotic and it was tending to come out from inferior end. And then I drilled these holes and I took them out, put a cemented modular bipolar. And when the cement was setting, I put the screws, and then this is the follow-up. She continues to do very well. So I often say, if I tried to do a hemi replacement after taking out the nail and fractured the bone here, I would have been forced to do something like this, but then the patient would not have been able to walk full weight bearing. Doing it prophylactically prevented that, and she could start walking immediately. And we have published this in the Journal of Osteoporosis and Physical Activity. Sometimes the osteoporosis in our countries is so severe that even by turning in the bed, the patients can fracture and have this kind of acetabular fracture. And we do a primary, because the age, primary Bert Schneider cage, and then you can make them stand and walk the same day. We have also published on the use of octopus cage. It's a hydroxyapatite coated cage as a primary total hip replacement in acetabular fracture in elderly, because they cannot tolerate multiple surgeries in case the osteosynthesis goes wrong. And we know that the osteosynthesis failure rates are very high in elderly patients, and the reoperation rates within 1 year are about 28%. We have looked at the anatomy of the proximal femur, and have also designed some special hip replacement implants with the Indian Institute of Technology, Delhi, and we have published that also. We have done a CT study to see whether the head neck offset is responsible for the low incidence of primary osteoarthritis in Indian patients, but we could find no relation. So this is another example. This lady had a juvenile inflammatory arthritis. So the surgeon could not negotiate the smallest possible implant into the femur. It was so narrow. So he caused fractures on both sides. So he was lucky he got away on the right side, the fracture united. But on the left side, it did not unite, and she came to me like this. Now, the ideal treatment for this would be a revision with the longer stem. But when the standard primary stem is not available with that dimension, where from I am going to get the revision stem? So this is what I did. I used strut allografts along with the locking plate with the locking attachment plates, and then put some bone graft substitute at the side. And she continues to do very well at 3 years, solidly united and walking. We have to keep the cost in mind. This is a 52-year-old lady who had tubercular arthritis, and she had a total hip cementless, but she pulled out everything after 3 weeks, and now there was a big defect. So I used trabecular metal augment with a normal cemented cup, so that the cost was kept contained, and she continues to do well at the 8 years after surgery. Ankylosing spondylitis, fused hips with fracture, infected on this side. Somebody operated, caused infection. This is fractured. There's no way it is going to unite. You try to fix it. There'll be so many stresses here because of the fused hip that the osteosynthesis will just break off. So I did I call it emergency arthroplasty. So did an arthroplasty with an from stem, and later on revised this infected hip also in 2 stages, and she does very well. And we published this. We have operated these kind of giant cell tumors with the allograft prosthesis composites, and we have published our results with the JBJS British. And then, of course, because of the bone bank which I have, we do often do the allograft prosthesis composite instead of the femoral replacement or mega prosthesis. In the last thing about hip replacement, the hip spine deformity, ankylosing spondylitis is another culprit for that. This one needed the deformity of spinal correction. So my spine surgeon wanted to correct it first. So the total correction required was 90 degrees, and it did multiple different types of osteotomies to correct it. And then we went ahead and did the hip replacement. So this is again something which is very important. We have written on the hip spine relationship, because that we know can cause hip joint instability. We have this EOS machine, which can actually do the X-rays in standing and sitting position, AP and lateral, and can give all measurements and can help in a great way for planning for the spinal deformities. Now, talking about the challenges in the total knee arthroplasty is anthropometry and age, diagnosis, deformity. They are often post-traumatic, and the infection. So we continue to be different from others. We squat, we sit cross-legged, we pray, we need high flexion. We have high incidence of rheumatoid arthritis, osteopenia, and osteoporosis. And very often the patients come late, compliance is poor, higher age and higher physiological age also. And we know that the in vivo normal knee kinematics is also influenced by ethnicity. Our patients are smaller and different, and their anthropometric measures are different from the Western population. Very often there may be a mismatch between the femur and the tibia. So you may be at a loss particularly if you're doing a PS knee. The only PS knee I have used in my life, which can give you excellent compatibility, was Vanguard, where you could practically put any femur with any tibia. Otherwise, when you use any kind of PS knee, you can only use a certain one up, one down, or two up, two down, which can sometimes lead you with a problem. So there are several unmet needs during TKR. Many times you will get this big bony defect here. You open and you find this, and then you don't know what to do. The components, the smallest component may be too big for the patient. There may be an overhang. We know that our dimensions for the knee replacement are decided by anterior-posterior dimension, but then very often that leads to medial lateral overhang. Now companies are coming out with a narrow option, but not every company has it. So if you have an overhang, it is a problem because that can create problem. If you use an undersized component, you can notch and then cause fracture. So underhang is a problem, and the overhang is a problem. So fit and function is a big problem. So femoral overhang is very common, almost in 68% females and 40% males. It can cause twice the high risk of pain in the knee. If the femur has more than 3 millimeter overhang, there's a 90% increased risk of having clinically important knee pain. And then suboptimal implant fit negatively impacts the knee balance and overall function. So we published this in JBJS Open Access as a part of the Asia Knee Research Team in how additional mediolateral implant options are necessary across ethnicities. The other problem is if you have to lateralize the tibia to bypass a defect, you may often hit the cortex. Can hit the cortex here, or anteriorly, and can even cause a fracture. You need a femoral stem in primary TKR sometimes, particularly if there's a very big defect in the femur or very severe deformity. Now, hardly any system will give you a stem extension in a primary femoral component. DePuy does that, Buchel and Papas does that, but not any other company does that. The other thing is to have the proper tibial component to have an optimum coverage of the tibial plateau, because if you overhang posterior laterally, you will irritate the popliteus, the patient will be unhappy, and very often a large part of the posterior medial tibial plateau will be uncovered. So tibial rotation is a problem, and if you try to give a good coverage and get your rotation wrong, the patients will be unhappy or there will be unstable patellofemoral joint. The other problem in the Asian countries is the coronal shaft bowing, and that can actually even change your transepicondylar axis into varus. So even if you follow transepicondylar axis, you will be actually rotated and you will be misguided because that changes as per the anatomy. So in this particular paper, it said that you can actually improve the tibial component placement during knee replacement with tibial bowing, and they said that you should in severe cases you should put the extramedullary jig not where it is but a little laterally. So that is how you do it. That means you actually accept a little bit of varus rather than causing a very valgus tibial cut and then doing extensive release on the medial side. So other preferences that, if your patient has severe bowing, you can actually slightly undercorrect, never leave your tibia in varus, but leave your femur in a little bit of varus, and then overall varus can be acceptable. So this is again, if you leave your tibia in varus, you can actually have a progressive collapse and the failure of the knee. And this has been shown that these knees don't survive for very long. So if you have a neutral mechanical alignment or residual mild varus, it is fine. It doesn't matter as long as your tibia is not in varus. So remember that you can be in 3-degree varus. Some people say even 6-degree varus, but nobody should leave more than 6 degrees of varus in the tibia because that compromises the survival of the knee arthroplasty. So for the age, we divide patients into 3 groups. Group 1 is less than 60 years of age, 2 is 60 to 70, 3 is more than 70. So when we have very young or very old patient, we look for AMOA And if it is anteromedial osteoarthritis, which means the ACL is intact, lateral compartment is intact, and only the anteromedial osteoarthritis is there, which is suitable for partial, we do a partial knee replacement. If the varus is not correctable, usually they are not suitable for partial knee replacement, then we do a total knee replacement. And we use something like a gold knee or an oxenium knee, a Verilas knee, in order to reduce the wear. So we got this grant from a national funding institute about 15 years back, where we showed that, so much of bowing in India causes a medial compartment osteoarthritis where everything else is normal. So it may be a good alternative to total knee replacement in this patient. So that also allows you to sit cross-legged and squat. So that was the time when 2008, I started popularizing the unicondylar knee replacement. And I think the Asian populations are particularly suitable for that. We have published on early results of the Oxford mobile bearing with a minimum 2-year follow-up. Average follow-up was actually 4.5 years in 2018. We have also gave our own recommendation for deciding the sizes of the implant, which is not in line with what the company recommends, because those are the British sizes. We have published our results with the newer instrumentation, the microplasty instruments, and we also published in Journal of Arthroplasty our observations that in those cases where the mobile bearing is moving very well, the patients are more satisfied. Where it moves less, the patients are less satisfied. So 60 to 70 years of age, the implant depends on pathoanatomy and the surgical challenges. And we often do bilateral TKR with patients who are fit. But group 3, which is over 70 years of age, we do only navigated TKR. And then we avoid PS designs because the bone is, strongest bone in the distal femur is in the supracondylar notch, and the PS removes that. So in poor quality bone, that can cause fracture. And we don't do bilateral TKR in patients over 70 years of age. So India is an incredible hub of comorbidities. So we have patients who have these. So we are very, very careful. So we published this publication in Journal of Bone and Joint Surgery American, where we showed that the embolic load is less when you use navigation. So in patients with comorbidity, as an extrapolation, we do only navigated. Rheumatoid arthritis is still about 1/4 of the cases in India, which has totally disappeared from the Western world. And that presents special challenges because the poor bone qualities, young age, muscle wasting, intraoperative fractures, and infection. And they have severe deformities, small bones. So we have shown good to excellent results in rheumatoid arthritis patients in knee replacement without patellar resurfacing, because very often the patella is so thin and osteoporotic that you can't do the replacement. But it's important to take away all the cartilage, because that cartilage leads to pannus formation. We have also published our results of rheumatoid arthritis with medial stabilized, which we think is the future, because medial pivot knee is going to be the ideal knee. The world is gradually catching up. We have been working on it for last close to 10 years. We have made several publications, and we feel that the medial pivot knee kinematically is the best knee. I'll not dwell much on it into how to deal with varus deformity, valgus deformity, flexion deformity, and hyperextension deformity. All of you do that. I'll just show you some example of the kind of cases. It's not uncommon to have very severe deformities in this part of the world, but you should be very careful about hyperextension deformity, because particularly when associated with Charcot joint, it may demand rotating hinge. Now, this is a patient with rheumatoid arthritis. This we did at a time when the long leg X-rays were not done routinely, and to our horror, post-operative, we found that this had happened. So this was actually uniting. The patient has no complaint, but in the meantime, 3 months later, because of poor bone quality, the patient presented with bilateral femur fracture. And then when we looked at the X-rays retrospectively, there were some impending fractures which we had missed, and then we had to put nails on both sides. Then eventually she came for surgery on the other side also, is walking now and is very happy. So one should suspect stress fracture in cases of severe varus and valgus deformity and plan implant accordingly. So always get the whole length scanogram. This was an interesting case. We did a hip bilateral total hip arthroplasty, and when we were hammering, we possibly caused the bilateral femoral neck stress fractures, and which had to be treated with arthroplasty. So we have an algorithm that younger than 60, we want to do the Oxford or a fixed bearing, mobile bearing arthroplasty. 60 to 70, we deal with it according to the bone quality. I hardly ever do the posterior stabilized design because I think it weakens the bone very considerably. The CR design with a option for dished insert and short tibial stem extension is my go-to. And if there are severe surgical challenges, you may have to go for a more constrained implant. If it's an old patient with comorbidities, we use navigation. This is an interesting case. We have done a few cases of gout. These are all tophi, and this is the intraoperatively. You can see there was big tophi, and I did the zirconium nitride coated cobalt chromium. Another interesting example, post-traumatic osteoarthritis knee. We get several such examples, and using a handheld navigation, we did not remove any implant. We just removed a few screws from here and a compression screw, and we could do a very good knee replacement. And we published our results, how to do a knee replacement and the outcomes following the knee replacement cases which have hardware around the knee. Another thing I want to tell you before I close is the sonication. We have routinely been doing sonication of the extracted implants. This is the sonicator, and our yield of infection organisms is much higher, and we are able to diagnose many more cases than with routine culture. And we have been able to diagnose several unusual organisms, and we have also been able to in the E4 Congress talk about the antibiotic stewardship. This is another concept original which we published 2016 in the APOA meeting in Melbourne. In cases of infection, we remove the previous implants, autoclave them, and loosely cement them and use a new polyethylene insert, and that reduces the cost, works like a articulating spacer, cuts down the cost, and many times they are so happy that they don't even come back for the definitive revision. Another thing which we have done is to diagnose metal allergy. We have seen in the Ki67 expression in the CD8 plus T cells. We have this facility, so we have been able to diagnose metal allergy and treat it. So I often say, if an infection is not infection, it's metal allergy. So if you see somebody who fails very quickly after the primary surgery and you suspect infection but cannot prove infection, consider that it could be a metal allergy. And then you have to use the Smith-Nephew kind of very last oxynium implant or a gold kind of implant, which are non-allergenic. So we have need for enhanced flexion for sports, for recreational activities. So we know that 26% patients are don't feel normal even after successful knee replacement. And that's where we have found that a medial pivot or a medial stabilized knee, as is called by some company, gives very high satisfaction and very good results. We have published this paper where we have shown that depression and pain catastrophe are also associated with poorer results. And in this particular study, we found that the widow ladies living singly were the most complaining types and had the worst results after knee replacement. In this particular study from India, the hip replacement patients are generally more satisfied than the knee replacement. So I'll just summarize by saying we had been doing 4 joint surgery. We published this paper in 2008 on the bony ankylosis in ankylosing spondylitis, and many of these patients had the contractures in the knee, contractures in the ankle. So we were operating on 4 or 6 joints. So both hips replacement plus knee flexion contracture release or tendo-Achilles lengthening at all. But then this was a person who came to us. This is after surgery. He came to me bedridden. His deformities were so bad that 1, 2, or 3 joints replacement would not have made him walk. So we did all 4 joint replacement in the single sitting. And then we have done another 7 after that. In 2018, we published the 5-year follow-up of this case. So that is also possible. So we had to find solutions to our own challenges. In TKR, 1 implant does not fit all. UKR is in very young and very old, particularly with the femoral and tibial bowing. The patient safety, navigation is a help. post-traumatic, does not require complete implant removal, and patient satisfaction and expectation should be met. And you should also know the psychology of your patient, because you may otherwise land with the patient who can be a potential litigant. In total hip, it has to be a conservative arthroplasty, leave room for the revisions in future. Direct anterior approach is especially useful. It leaves the posterior tissues virgin for a subsequent revision in case somebody wants to do it from that approach. Modern implants are available for younger patients. Emergency arthroplasty is required. You need algorithms for soft tissue release, and you need innovation to reduce cost. I thank you all for your attention.
Thank you so much, Professor Rajesh. Dr. Srinivas, thank you so much, sir, for your marvelous presentation.
Thank you, sir.
Thank you very much, sir, for the presentation. I would like to express my sincere thanks for your talk, and your insights on this topic were invaluable, and the presentation, as always, engaging and educative. The cases were complex with great tips on management of the cases. Just a couple of questions. I think there is none at the moment, but
I have a question, sir, please. Dr. Srinivas. Dr. Rajesh, thank you so much for this excellent presentation. I think you have summarized all the problems we have seen in hip and knee replacement. And I think for me, the problems are the same in India and in Egypt. We face the same problems with arthroplasty patients. Can I have some questions to you, sir, please?
Please,
my first question is that in some deformed cases and dysplastic cases, when we are doing a hip replacement, we are enforced to put the hip in a higher hip center because the reconstruction of the acetabulum is very difficult to put the hip center in the proper position. How much do you accept a higher hip center when I'm doing the hip replacement, especially in revision hip, sir?
So that's a great point. And, this is being talked a lot because it's sometimes very difficult to put the hip in real hip center. And you have to do a femoral shortening if you're putting it in the real, in the original hip center. If you put it at a higher hip center, you may not have to do shortening and there's better bone. Ideally, it is said that you can accept 5 millimeter higher hip center, but I would say even up to 1 centimeter is fine. If your lower end of the cup is above the teardrop, that's when you start getting into trouble. So that is what one clue I can give you, that the lower margin of your acetabular cup should not be proximal to the proximal extent of the teardrop.
Yes, sir. Thank you so much. Another question, sir, please, for the conservative hip replacement and for using the short stem hip. I worked with the short stem hip in Germany about 10 years ago, and the era of short stem was going up like that. But now it's, I don't say it's stationary, it's a little bit declining. In your opinion, what's the reason for this? Is this because of the metal problems, or what do you think, sir?
No. I think some of the designs have been doing very well, like the Mayo hip, like the Meta. But what happens is the Meta from B. Braun, which is one of the commonly used stems in Germany, they came out with a modular neck, and that was its unbecoming. So the moment undoing. So the moment you put a modularity in the neck, it's a disaster. We had a connective hip from the Zimmer, where they had great idea. You put the stem and then you have the necks of different kinds. So every time you put a zero head, so that is the ideal head neck ratio. But that was a disaster. So the problem is, one, availability, because B. Braun is not available everywhere. On the other hand, what all companies have started doing is they have started reducing the length of their standard stems. So every company has come with short stem now. So the short stem is here to stay. The problem is with neck retaining stems. So the neck retaining stems like Proxima, it was a failure because it had a very big profile, very big shoulder laterally. That was compromising a lot of bone. And you could put it round the corner, around the shoulder, but you could not take out round the shoulder. So what is the point in conserving the bone at the time of putting the joint, if while taking it out, you'll destroy all the bone? So it's no good for revision. So I think the problem has been the availability of good designs, because you see, if you preserve the neck, it is 230% more resistant to torsional and bending forces. So I have done more than 1500 short stems and I have not revised a single one till date. And because my patient is young, if I have to revise it, I can put a standard stem. So it has given him another bite at the cherry. So I think what people have done is, because they are not, for one reason or other, happy with the neck preserving stem, they are going to short stem. So short stem is not out. They are making, every company is now coming with short stem. So one of the arguments, I had a big debate, with one of the biggest proponents of cemented stems in the world. And I told him, I put cementless in a young patient because I can put a short stem. So he argued, but later on he showed that the Exeter is coming out with a short cemented stem. So short stem is something nobody will able to avoid, because we have seen, I've already shown you a 25-year-old who is already now compromised for 190 millimeter. 19 centimeter is gone. So whatever, after 10 or 12 years, he'll go to 29 centimeters or 28 centimeters. So he will go for total femoral replacement by the time he's 60 or 65. So that is the reason for using. So I still do a resurfacing I showed you. That was done about a year back. And that's because the patient wanted it. He understood everything. He understood the problem of metal on metal and see the things he's doing. And, if his metal ions are fine, I have no problem in letting him do whatever he wants to do. On the other hand, if I put ceramic on ceramic, if he jumps like this, I'm worried that he may fracture. So I cannot allow him high impact exercises. So I think you have to fit the implant to the patient, not patient to the implant. So you have to see what your patient needs, what are his demands, what are his requirements, but generally use the shortest possible implant which will work for him.
Yeah, I see you, sir, that you are trying to preserve bone as much as possible. One of your cases, sir, I think the first case, you are trying to preserve the bone, although it was an eggshell bone.
Yes.
For me, I may do a proximal femoral replacement, I think.
That's right, sir. But then the proximal femoral replacements also have to take anchorage in the same osteoporotic bone. And after a few years, you will find that it is becoming loose. Yes. And then it will be total femoral replacement. Yes. So that is what, we are forced to. I have a bone bank. So very often, in the most severe osteoporosis, I put in a stem and then I put the cortical struts all around and wire them. Yes. So that way it does not fracture.
Do you use Navigator, sir, routinely in your complicated cases?
Yes, sir.
Yes. Thank you so much, sir. Thank you so much.
Thank you. Thank you, sir.
Dr. Salivas?
What is your approach for severely osteoporotic patients for the hips and the knees, sir? And what DVT prophylaxis do you use?
So generally for very osteoporotic hips, I use a cemented stem, but then there are certain designs which do very well even with a cementless. For example, there are studies on taper lock. The taper lock stem by Zimmer has been shown to perform very well in the osteoporotic bones, but then I would generally not hesitate in using a cemented stem. As far as the femur is concerned, I will avoid doing any PS knee, because a box takes out the strongest bone from the distal femur. Secondly, many designs have a box and a peg. Now, if you have a rheumatoid which has got a flexion deformity of 40 degrees, you use an oversized femoral component to stuff the flexion space, and then you take out a big notch, and then you have two pegs going into that osteoporotic bone in the lady who has not walked for many years. You will have a condyle fracture. So we try as much as possible to go for CR knee, and I use only those CR knees which have an option for the deep dish or the ultra congruent option. So I used to be a big fan of the Zimmer knee, but the Zimmer next gen never had a CS or the ultra congruent insert. So when I shifted to CR because of the box and the peg design, I was not comfortable. So I changed the company. Now that the persona has come, I can again go back, remove the PCL and put a ultra congruent or a dished insert. So that will be my choice in osteoporotic bone in knee. I'll use a stem on the tibial side. I'll cement it. I'll use a CR knee on the femoral side, try to preserve as much bone as possible. I'll be treating the osteoporosis by whether it is denosumab or zoldronic acid and give calcium and vitamin D. And sometimes in severely osteoporotic bone, I'll be very careful. I'll put them on gradual weight bearing, particularly if the patient has not walked for a long time, because I have seen and treated patients who have been operated and then they started walking and had fracture, supracondylar fracture of the femur, because their bones were so weak that they hadn't walked for a long time. So you have to keep those in mind.
Use
And
a
my
stem
DVT prophylaxis, is largely fast track surgery, early mobilization on the day of surgery, DVT, the TED stockings, and the DVT pump and the aspirin. But in very high risk cases or cases with a past history of DVT, I'll not hesitate to use low molecular weight heparin.
And if a lot of Indian patients, as you have in your presentation shown, that they prefer to go into the squatting position, what is your advice on for such patients in the knees?
I do a lot of UKR because I tell you there are comparable studies head to head where say that the risk of death, risk of ICU admission, risk of major complications is much less. So if I have anybody above 70, particularly with any comorbidities, if a UKR can be done, I will do a UKR. And with UKR, they can easily squat, right? But even with the normal knee, if they have good range of motion, they can squat. So here is what I tell them. They said, what are the precautions? I said, you should not use an Indian type of toilet and you should not sit on floor. Now, not that you can't do it, but if you can squat like an Indian toilet, but you can't squat for 20 minutes or 15 minutes. And if you do that, the wear and tear on your joint is much more. So you are better advised not to try these things in the interest of your knee joint. But if you have to perforce sometime, you can do that, but it's not advisable.
Thank you very much, sir.
Thank you.
Thank you so much, Professor Rajesh Malhotra from India, for this very, very interesting presentation. It was an honor for us, sir. Thank you so much, sir.
It's a pleasure and an honor for me, sir. Thank you so much.
Thank you so much, sir. Now we will move to the next speaker. Our next speaker will be Professor Mahmoud Mabrouk from Egypt. Professor Mahmoud is one of the eminent stars of arthroplasty in Al-Azhar University and in Egypt. Professor Mahmoud will speak about the adult dysplastic hip. Professor Mahmoud.
Thank you, Professor Rajesh. Very nice collecting cases, really very difficult and interesting cases. Still, we have time, or I think because 1 hour passed now.
No, we have time, sir.
We have time because
we have a lot of time, sir.
Huh?
We have a lot of time.
Okay. What I have done, I understood from you that it is something to some degree teaching lectures or something like that. My talk may be very smoothly or smooth or easier than that most of complicated cases Dr. Jarish has shown us. So total hip replacement for adult total hip replacement for the patient with a dysplastic hip is challenging. The normal anatomy about the hip joint is distorted in the presence of abnormal acetabulum and the proximal migration of the femur. Problems during total hip replacement and hip dysplasia are related to surgical technique, placement and coverage of the cup, lip length discrepancy, femoral deformities, soft tissue contractures that should be solved during operations. Normal development of the hip requires normal growth of both acetabulum and femur. According to that, hip development may be affected by many problems as DDH, Persis, left capital femoral epiphysis, cerebral palsy, poliomyelitis, physical injury, sepsis, like Dr. Have shown us. Dysplastic acetabulum becomes shallow, oval opening, usually is deficient anteriorly, laterally, and superiorly. The medially is okay. The anteromedial aspect of the acetabular wall may be very thin. The affected side of the pelvis is smaller, and the acetabular wall is thin, soft, and grossly anteverted. The dysplastic anatomy of the proximal aspect of the femur also include a small head with a short valgus neck with marked anteversion. Posterior displacement of the greater trochanter, narrow tapered femoral canal, tight isthmus, and anteroposterior diameter is wider than the mediolateral one. And this illustration showing the distorted anatomy of the proximal aspect of the femur with short distorted head and short neck valgus, and also severe anteversion. This model clearly shows the posterior position of the greater trochanter and the crooked proximal aspect of the femur. Diagram showing a second hip capsule with proximal migration of the femurs. Also, all these problems and for dealing with the dysplastic hip, soft tissue are abnormal, particularly relatively horizontal orientation of the abductor muscles, but also all muscles around the hip, the hamstrings, the adductors, the quadriceps muscles are short. The sciatic nerve, femoral nerve, and the profunda femoris artery are shortened and may be vulnerable to injury. For most patients, pain in the hip is the primary symptoms. And although a major limb leg length discrepancy, severe limb pain in the back or symptoms in the knee commonly can be present. Patients with developmental dysplasia of the hip often have fatigue in the hip early in the adult life, may have a marked limb leg discrepancy, and usually have an abductor lurch. Many have no symptoms until middle age when they have pain in the back, secondary to exaggerated compensatory lumbar lordosis. Patients with bilateral hip dysplasia have a positive Trendelenburg test bilaterally and walk waddling gait. Symptoms are and functional aims of the patients should be carefully assessed. Many patients with bilateral dislocations maintain satisfactory function into later life with a severe limb, but with little pain because no arthritic changes occur in these cases. To deal with this problem, we have classification. We have most common classifications. The classification of Crow is widely accepted as a method to categorize these degrees. Other classification systems also are used, including that of Arthroplasties kids. The amount of subluxation could be determined easily from the anteroposterior view of the pelvis by noting just 3 easily identifiable landmarks: the height of the pelvis, the head-neck junction in the dysplastic hip, and the inferior margin of each teardrop, as this show. This is the height of the pelvis from the highest point of the iliac crest to the inferior margin of the ischial tuberosity, and the line from the head-neck junction on the right side, the head-neck junction up to the enter teardrop line, and the pelvic vertical height. This can give us landmarks about the proximal displacement. If we divided the head-neck junction over the pelvic vertical height, it gives us a ratio. If less than 10%, it is grade 1, 10 to 15, grade 2, 15 to 20, grade 3, and greater than 20 is grade 4. If we consider the subluxation, Grade 1 is less than 50% subluxation or contact with the true acetabulum. Grade 2, 50 to 75. Grade 3, 50, 75 to 100. And grade 4 is greater than 100% subluxation or complete dislocations. And we can just to look for X-rays. Group 1 or grade 1 less than 50% subluxation in the right side, and grade 2 from 50 to 75 subluxation. Grade 3 on the left side, and a grade 4 on the right side. That's on the left side 75 to 80% subluxation. There is overlapping of the false acetabulum over the true acetabulum, but on the right side, grade 4 is completely, the false acetabulum is completely separated from the true acetabulum by a normal bone, as we have seen here. This is also the degrees of dislocation. Hard to feel is one of the most topical classifications. Type 1, it is subluxation. It equals type 2 and 2 and the first classification, in which the femoral head is still within the true acetabulum. Type 2, low dislocation, in which is the femoral head if in a false acetabulum, but the inferior lip of this false acetabulum is in contact or overlaps the true acetabulum. Type 3, high dislocation, in which is a false acetabulum has no contact at all with the true acetabulum. As we have seen here, grade A subluxation. Type 2 is false, is still type 2, low dislocation. The false acetabulum is in contact or overlapping the true acetabulum, and the true dislocation or high dislocation, the grade type, grade 3. Group 3 hips, low dislocation, and group 4, high dislocation, present the surgical surgery with certain technical problems that must be addressed during the planning, during implantation of total hip replacement. These problems are related to limb-leg discrepancy, placement and the coverage of the cup, the need for small femoral acetabular components, and the surgical technique. For radiographic evaluation, sharp angle, if sharp angle greater than 45 degrees seen in patient with hip dysplasia. Sharp angles, as we have seen, it is an angle between the horizontal of teardrop and the line drawn from the teardrop to the lateral edge of the acetabulum. If it is more than 45 degrees, it is dysplastic hips, of course, in adults. And also the acetabular depth ratio, values of this ratio inferior to 250 is seen in hip dysplasia, and this ratio can be calculated as the depth over the width, the depth D in this photo, the depth over the width multiplied by 1000. If it is ratio less than 250, it is hip dysplasia. Also, in these lines, we can see the femoral head coverage inferior to 75% or femoral head extrusion greater than 25% are seen in patients with hip dysplasia. CT scan should be done in many cases in adult hip to look for the deficient or area of defect, acetabular defect. And the treatment plan, as a rule, patients who have class 2 or 3 dysplasia according to Crow classification tend to have degenerative changes, and symptoms appear earlier than and to need replacement at a younger age than the patients who have class 1 or 4 dysplasia. Despite the markedly abnormal radiograph appearance in patients with bilateral class 4 disease, often these patients do not need operative intervention because they have little pain, usually because they have no arthritic changes, only limb length discrepancy. The treatment depends on the severity, extent of secondary osteoarthritic changes, age, functional goals of the patient, availability of bone stock. So non-operative treatment or support measures indicated as first line of treatment, and this may be for grade 1 and grade 4 in many cases. Operative, either osteotomy. The goal of osteotomy is to, on the pelvic or femoral side, is to re-establish normal hip biomechanics and preserve the longevity of the hip. And usually this can be done in the pediatric and childhood age. Arthrodesis maybe we have seen many cases in the 1980 and the 1990 in heavy worker laborers. We can do something like that, but now it is not done. If not, a candidate for osteotomy or total hip arthroplasty. It is contraindicated in morbid obesity, systemic arthritis, contralateral hip disease or ipsilateral knee problems, or lumbosacral spine diseases. Resection arthroplasty, I think we don't need it now. A hip resurfacing can be used for a crowd type 1 or 2 diseases, but total hip replacement is the rule for this, the treatment of these cases. Treatment of last resort for these with severe arthritis. Preferred treatment for older patients above than 50 years and those with advanced structural changes. In a patient with bilateral hip dysplasia, there are significant technical challenges that need to be addressed to ensure a successful hip arthroplasty. The planning of treatment will be acetabular placement and coverage and femoral reconstruction. Regarding the acetabular placement and coverage, according to Crow classification, type 1, mild dysplastic hips, less acetabular bony deformity and good bone quality, mostly reconstruct with a standard acetabular component, standard total hip replacement, placed in the acetabular region with safely medialized to the inner acetabular wall. Grade 4, this is grade 1. Grade 4, in most cases, the acetabulum can be reconstructed with an extra small acetabular component at the anatomic hip center without bone grafting, but should be with femoral shortening, osteotomy. Crowd type 3 and type 2 and 3 hips, acetabular deformities are the most difficult to be reconstructed, and their management is the most controversial subject. In some cases, sufficient lateral coverage of the socket can be obtained at or near the normal anatomic position by deepening the sockets with ream to the medial wall. When this is not feasible, there are other alternative methods for reconstruction can be used, either to use buttress bone graft or high hip center or cutuloplasty or metal acetabular augmentation. Bone grafting, the bone graft provides additional support for the cup and allows the use for standard sizes of the acetabular cup. Either the patient's own femoral head or an allograft can be used, but the outlook is better with the use of autogenous graft. The femoral head is used for the bone graft. The cartilage is reamed from the acetabulum off, but the subchondral bone is kept intact. The cancellous surface of the graft should not be exposed to host soft tissue because the surface is more easily resorbed than the subchondral bone. Decortication and the drilling of numerous holes in the outer surface of the ilium, like to be a good bed for the graft to promote healing of the graft to it. The best graft should consist of firm trabecular bone on the medial side and cortical bone laterally, and should be devoid of remnants of articular cartilage. The graft is placed at the superior edge of the acetabulum or just inside it, and is fixed with 2 or 3 cancellous screws, usually 4.5 millimeters in diameter. The screws are placed in an oblique or vertical directions. In this case, bone graft fixed with 3 screws superior-laterally. The failure of the bone graft may be related to the fact that the trabeculae of the allograft are not oriented in the direction of the forces going through them, and so the screws, the graft and the screws should be in the line oriented in the direction of the forces going through them. This is an example on the right side for cementless total hip replacement in dysplastic hip, was fixed with 2 screws. On the left side is an example of the cutuloplasty. We will look at now. This is a patient, male patients with bilateral dysplastic hip, crowd 2 on the left side, preoperative X-ray. On the right side, grade 3. And this is treated by this graft, cementless total hip with the graft, autogenous graft, and 6 months and the last follow-up with good function, also complete flexion, external rotation. Cutuloplasty, this procedure advances the acetabulum medially, but the creation of controlled comminuted fracture. We induce a comminuted fracture in the floor or in the medial acetabulum, and a small cup is then inserted with or without semen. Like this example, radiograph makes 6 years post-operatively showing the position of the cup medial to the cochlear line after performing cutuloplasty. The medial periosteum is usually left intact, but reaming through it can also be done, and the iliacus muscle is then seen in the base of this defect. But better just to, when look for the periosteum, just finishing your comminuted for the fracture or inducing the fractures by sharp small osteotome. And the fractures, usually the defect must remain only medially, with no more than approximately 25% of the area of the acetabulum performed, just 25%. If you exceed this percentage, may the cup protrude inside the pelvis. More extensive perforation can result in cases much as 45% of the surface area of the cup protruding behind the cochlear line. High hip center, as Dr. Professor Al-Ashhab asked, there are technical problems associated with reconstruction using a proximally placed high hip center. A small or so-called many sizes of acetabulum component may be needed. The length of the limb will be reduced unless the length of the femoral is part of the reconstruction is increased by use of the femoral component with a longer neck or of calcar type femoral component. Usually up to 2 centimeters, you can use the high hip centers and compensate for the limb length discrepancy by using femoral component with longer neck to compensate for shortening. It is necessary to osteotomize and displace and advance the greater trochanter to restore proper tension of the abductor muscles. As we have seen, the right hip with use of uncemented cup in a high positions, about 2 centimeters maybe or more, with long neck in the prosthesis, while in the left hip we had used reconstructed the acetabulum with uncemented cup and shelf autograft. The last one is metal acetabular augments, and really most of us now use these metal augments to compensate for the defects in the acetabulum. Many shapes and many types of the augments are now available to be used for all acetabular defects. Right, dysplastic hip, crowd type 2, and post-operative with use of metal augments, 6 and 12 months. Crowd type 1 and type 2 hips, because the acetabular reconstruction usually no change in the hip center of the rotation available. Length is not, sorry, we are now with femoral reconstruction. For femoral reconstruction in crowd type 1 and type 2, usually we don't need to do any osteotomies for the femur. Length is not a major problem, and the femoral shortening usually or generally is not needed. Crowd type 2 and 3 and 4 hips, when the center of the hip rotation is broad from markedly elevated position down to the normal position, femoral shortening usually required. Without shortening, soft tissue contractions make it difficult to reduce the prosthetic femoral head into the acetabular component. leg length discrepancy and the neurovascular injury may result, and we have seen cases like that. The limb is lengthened by lowering the acetabulum back to or nearer to the anatomical position, or by inserting a femoral component that is longer than the length femoral bone that is removed. With a high dislocation crowd type 4, when it is present, soft tissue contractures and concern about sciatic nerve stretching make it difficult to reduce the prosthetic femoral head into the acetabular component in the anatomical position. The exact amount of distraction that will cause sciatic nerve dysfunction is not known, but acute lengthening of more than 4 centimeters has been associated with increased risk of nerve injury. Really, we have seen cases with less than 4 centimeters and have some sort of sciatic neuropraxia, and sometimes 5 centimeters and no affection of the nerve. But we usually keep to the rule that 4 centimeters is enough. Otherwise, you should do shortening. The sciatic nerve must be carefully monitored in all cases in which the limb is to be lengthened by more than 2 or 3 centimeters. The nerve should be identified in order to check its tension after reduction of the true components. The femoral nerve also may be damaged in excessive lengthening. This nerve is not monitored intraoperatively, but it should be evaluated post-operatively along with the sciatic nerve. If the femoral nerve palsy occurs, the patient should be positioned in bed with the hip fixed to with the hip flexed to about 70 degrees in order to relax the femoral nerve. When the estimated amount of lengthening required exceeded 4 centimeters, iliofemoral distraction was done prior to total hip arthroplasty. The pins were placed in the iliac crest and the distal part of the femur. The distraction should be done with a rate of 2 centimeters on the first weeks, and then first day, and then 0.2 centimeters per day thereafter, like this external fixator for iliofemoral distraction in the iliac and the femur. The main disadvantage of the iliofemoral distraction technique are the need for the iliofemoral external fixator to be in place for approximately 2 weeks, and the potential of infection, tract infection, sinus tract infection at the site of the total hip replacement due to infection at the points of fixation pins. So the femur osteotomy or femur shortening osteotomy can be proximal femoral osteotomy or subtrochanteric femoral osteotomy, and this is the most commonly used. And this can be fixed only by the stem or can be added by graft or plating. And distal femoral osteotomy shortening, like this. This female patients about 30 years. I don't know. Diagnosis right dysplastic hip crowd 2. She came with us. She maybe she has this plate with screws. The plate is completely embedded inside the bone, and we think how to remove this imbalance to do our arthroplasty. And when I open, I just removed the screws and left the plate like strut, like bone strut inside the cortex, and we have done cementless total hip replacement. This is post-operative view 6 and last X-rays, and post-operative functions also: complete flexions, kneeling, external rotations. This male patient, 45 years, diagnosed right dysplastic hip crowd type 2, preoperative X-ray and post-operative X-rays, 6 weeks, 6 months is last follow-up, with post-operative also condition. Thank you.
Thank you so much, Professor Mahmoud, for Mahmoud Mabrouk, for this very interesting and educational presentation. Thank you so much, sir. I want to ask you a couple of questions, sir.
Yes.
My first question is regarding the cotiloplasty, which is, I think, a very interesting topic. how can I guarantee, sir, that when I'm doing this comminuted fracture in the medial acetabular wall, it will not exceed 1/4 or 25% of the medial acetabular wall?
Usually you need to just do by sharp small osteotome, just do some cracking or fractures in this area only on the floor of the acetabular. And yeah, you should consider, or you should look that you have only 25% or 30% of this area which you have already done the comminuted fracture. And you should stop when you look and see the periosteum. You should stop. Don't go behind this line, and leave every this bone at itself as comminuted. It will heal very well, and put your component, acetabular component, so deeply. Usually it is a small acetabular component. It will be covered by the reaming of the floor of the acetabulum. Usually we have in the adult dysplastic hip, we have a very good bone reserve medially, and so go through this bone until you reach the floor. Do some cortical fractures and leave it, and use either cemented or non-cemented cups.
Do you put a graft, sir, with this comminuted fracture?
No,
you don't put a graft.
No,
you
no,
don't put a graft. Sir, I liked your case with this plastic hip, that you removed the screws from the plate and leave the plate and put your cementless hip with the plate just inside. That's what exactly Professor Ramesh Professor Malhotra has said, that we shouldn't strive for removing the implant, because I may fracture the lateral cortex. And as you said, sir, the plate was embedded in the bone. So if I try to remove the plate, I can fracture the lateral cortex, or even the lateral cortex will be very weak. So we may do an intraoperative fracture, periprosthetic fracture. That's exactly the same as Professor Malhotra has done.
Yes, yeah. If you like to remove this plate, really you do some sort of trochanteric osteotomy.
Yes,
you
sir.
will remove the area window, a big window from the lateral cortex, and you can't guarantee what do you do with the other grafting and the thumb. But we tried just to, by using image intensifier, just to go on the head of the screws, just to look for the head and try to remove it and leave the plate inside the bone, the lateral wall of the femur.
Yes, I'm saying this comment, sir, because some of the surgeons, arthroplasty surgeons, insist on removing the metal hardware, although, as you said, sir, it may act as a buttress for the lateral cortex.
Yes, it will weaken. You will weaken the lateral cortex, and you can't guarantee if you go even with the stem. You need a long stem, and you can't go. You can't guarantee when you are doing reduction or when you are doing hammering, the femur will be explored.
Yes, sir. We have a question from Dr. Yaqub for you, sir. The approach used by Dr. Mahmoud for DDH.
Usually I use the lateral approach. Always I am using lateral approach. And so I am not feeling the sciatic nerve. Maybe the people who are using the posterior approach can feel the sciatic nerve, but usually I'm using the lateral approach.
Yes, sir.
Hardened, modified hardened.
Do you use a special stem for the DDH, sir?
The smallest stem can be, usually there is very narrow canal, especially the isthmus is very narrow in most of cases, and you don't you can't go with a very big or large stems, and so the smallest stem we can use and can engage it good with the bone. We use it, as we have seen in our cases. Most of them are smooth and thin stems, small stems.
Yes, thank you, sir. Dr. Sarnifas, we have any other questions to Professor Mahmoud Do you want to ask anything, sir?
There is muted, Dr. Servet.
Dr.
Please,
Srinivas, you are muted, sir.
You are muted, yes. I don't hear.
Thank
Yes.
you very much, sir, for the presentation. Just wanted to ask one question. What is the maximum amount of length you have gained without sciatic nerve injury in these cases?
I have lengthened about 5 centimeters for one, and just post-operatively, I asked my juniors, tell me about the neurovascular immediately, and he told me that he has some weakness in dorsiflexion of the ankle and some numbness of the leg, and I told him put the patient on the sound side and flexes the hip, extends the knee or leg, leave the hip in the neutral position and flexes the hip. And we will give anti-edematous treatment and anti-inflammatory just for 1 or 2 days. But immediately, maybe 6 or 8 hours, he started to move his ankles and left the position for about 24 hours or 48 hours, and he returned again.
Yes, thank you so much, sir. I think we have reached the end of our presentation and our scientific day. Finally, I would like to thank Professor Rajesh Malhotra from India, Professor Mahmoud Mabrouk from Egypt, my dear friend Dr. Srinivas from India for his great support to complete this course. Thank you for our attendees. Thank you for Ortho TV for streaming live our presentation. Thank you for the Egyptian Orthopedic Association for streaming live our presentation on the site of the Egyptian Orthopedic Association. Many thanks to EVA Company for sponsoring this course. And finally, we will meet on next Friday, inshallah, with 2 presentations on infection of the hip and knee arthroplasty, the infected arthroplasty. One of our dear colleagues from India and one of our dear colleagues from Egypt. And we will see you in next Friday. Thank you so much.
Thank you.
Thank you.
Thank you,
Thank
sir.
you, sir.
Thank you, sir.
Thank you, Doctor.